So this is the first start of the shoulder joint. Like I said, probably won't cover it all today, so I can let you guys get out of here a little bit early so that you get to lab, but we'll start with the shoulder joint. So yesterday we talked about the shoulder complex, which is everything outside of the glenohumeral joint. Now we're going to talk about the glenohumeral joint itself, so the interaction of the humerus on the glenoid fossa. So when we're talking about the shoulder complex, we're kind of talking about all of this. When we're talking about the glenohumeral joint, we're talking about that. They have to work in concert, but they are two separate articulation sets. So motions at the shoulder joint. We have flexion, right? We have extension, which is return to zero with the shoulder. And then we have hyperextension, where we go backwards. And I'm cheating. Stand up right, Mr. McKeever. Right? We have ab and adduction. We have outside a medial, lateral rotation, horizontal ab, horizontal adduction, and we do have some circumduction, which is a combination of all the movements, right? I remember when I first taught this class, I said that shoulder flexion is 180 degrees. And the person's like, well, no, it's not. It's 360 because I can go like this. Well, in reality, what you're doing is you're hitting flexion, then going out into abduction, and then going into hyperextension, and then coming back into flexion to get that circumductive action. And then we have a very specific term called scaption. Have you guys talked about scaption in anatomy? All right, so scaption is a functional motion. Flexion, abduction, extension, adduction are not functional motions. We don't go, I am going to reach for the can on the shelf. Flexion, 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 flexion. Abduction, 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 abduction. Grab can, adduction, adduction, adduction. Extension, 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 extension. That's not the way we work. We work in diagonals. So scaption is midway between flexion and abduction. So scaption is out here at a 45-degree angle. Why is this important? Because at that angle, we combine a lot of our delts working in concert with a lot of our rotator cuff. So when we have rotator cuff tears, a lot of times you'll have patients doing scaption flexion in order to work it, because it's a real simple motion that kind of combines all of the muscles of the shoulder. And if you do that for a long period of time, so let me see if I've got a heavy book over here. There we go. This looks like a nice heavy book. Essentials of Musculoskeletal Care. Right? You come out here to that 45, that is a really tough motion to do repetitively. And you'll feel after a while that burn happening. Good Lord, that's a heavy book. Good thing I read that whole thing. So scaption is midway between the two positions. It's at 45 and it's functional. If I'm reaching up the shelf, I'm really doing a scaption motion, not a pure flexion and abduction. And if you do the flexion, abduction, adduction, extension, you're weird. So here's kind of our motions. So one thing to note, I know that this picture shows palm down for these motions, right? So they show flexion, palm down. If you do flexion, palm down, eventually you're going to hit the roof of your scapulothoracic joint there, right? It's going to lock. Most of the times when we are going for full flexion or a full abduction, the thumb is going to be up, right? What we often call that is open can position. And the reason we say it's open can position is because if you're holding a can, that's the way you're going to lift the can up, right? Or full can position. Versus sometimes when we're working exercises with patients, we'll call them empty cans. Well, empty cans, luckily this is still closed. Empty can position is where you turn the can upside down and you do the same motions. So that's an empty can position. This is an open or full can position where when the can top is up. And the reason I say that is with the thumb up, you're able to get that full scapulohumeral rhythm going on. with the thumb kind of flat or even down, you're not. You're going to hit the roof of that kind of area of your shoulder. And you can feel it, right? If I put my thumb down and come out here to do abduction, I kind of get stuck, right? I have a little bit of that passive insufficiency going on. It's not letting me do it. Medial and lateral rotation or internal external rotation is probably the hardest one for people to get, because when I have my arm here, right, where it's 90 degrees at my side, internal external rotation makes sense. If I bring my palm into my body, I take my palm away from my body. Internal external rotation makes sense. When we are testing and doing exercises on internal external rotation, we do it at 90 degrees of abduction. So out here. Same motion is going on, it just for some reason this position confuses people. So I have to say when the hand goes down, you're in internal rotation. Because if I bring this down here, I'm internally rotated. Go up here, external rotation. It's going to be important because make sure when you get questions on your boards or any of my tests, if you get a question on internal external rotation, move the motion. Right? Don't just go, oh, well, right? So most of our stuff that we do on a daily basis has some combination of flexion and abduction, and we always kind of return to extension. But we also need functional internal and external rotation, right? What kind of stuff do we need to do to have functional internal rotation? Ladies especially, you need to have functional internal rotation for the most part. This is going to be a big problem when you're working with patients, especially female patients. What do you need internal rotation for as a lady? Because internal rotation is going to be reaching back here. Yes, putting on a bra. You'll be amazed at how many older women lose that internal rotation and lose the ability to wear a bra. And I'll never forget the first time I worked with a lady about this. She was about 75 years old. And I said, well, you can always get a front clasp bra. And she looked at me and she goes, I ain't no hussy. And I just kind of laughed. I'm like, really? You're going to struggle instead of doing something that would be easier for you, whatever. But yeah, putting on a bra, right? External rotation we need for washing our hair, right? We need internal rotation for, guess what? Self-cleaning after defecation. So we do need all of these motions to get us going. The only one that's kind of weird is that horizontal ab and adduction. I mean, we do some motions that, but it's not like we're going, yay, on a daily basis, right? Unless you're clapping for kids. So bony landmarks, we have the scapula itself, right? We have the glenoid fossa, which is important. You cannot palpate the glenoid fossa. If you can palpate the glenoid fossa, the person's got a problem. Because you can stick your finger in the glenoid fossa, that's where the humeral head's supposed to be. The labrum, which is responsible for deepening that fossa and allowing the head to kind of get sucked in, like we talked about with the hip. You have the subscap and infraspinatus fossa, the supraspinatus fossa, axillary border, and acromial process. All of those are going to come into play when we talk about the glenohumeral rhythm. So we already talked about this. The labrum I like to think of as just a rubber band around that glenoid fossa to deepen it. Acromium is going to come into play because we talk a lot about AC impingement, which we'll talk about then. But a lot of the fossas serve as an area for a muscle to start, right? Those are those origins of most muscles. What muscle originates in the infraspinatus fossa? What muscle originates in the infraspinatus fossa? Infraspinatus, good, right? What one do you think originates in subscapular fossa? Subscap, yeah, right? And then supraspinatus fossa? Supraspinatus, at least the shoulder. I hope that was pouring water. The supraspinatus fossa, all those fossas are named because of where muscles start. That makes it easy for you at least, right? Some people, when I get to this part of the lecture, they're like, why didn't I figure that out back in anatomy? That makes so much more sense now. If that's the way you feel, that's okay. There's a lot of people that feel that way. It's not just you. So on the humerus, right, which is our real funny bone, we have our humeral head. And then when we talked about this in anatomy, we have our surgical and anatomical neck. Again, surgical neck is what we're going to deal with when we have to do humeral replacements, whereas anatomical neck is really the neck of the humerus. We have the shaft, right? The humerus has always given us the shaft. Greater tubercle and the lesser tubercle. We have the deltoid tube, right? Deltoid tube's one of the ones I've always found hard to find, mainly because that deltoid is really kind of thick. So when you're palpating it, I come down until I find a little sensitive spot. When we were training in the martial arts, that was an area we were trained to attack, was that deltoid tuberosity, because if you can paralyze the delts, that limits a lot of your enemy's motion of the shoulder. You have the bicipital groove or the intertubercular groove. So it's either the bicipital groove or the intertubercular groove. So the groove between the tubercles, where one of your biceps is going to pass. And then you have your bicipital ridges, right? So all of that comes into play when you're working with that actual shoulder or that humerus. Now there is a small thing called the spinal groove for the radial nerve. Is it important? Yeah, but for PTAs, rarely do we deal something there. But when we have these grooves, you can find all of these landmarks. The only one you can't really palpate is the head and the neck, right? But I can find, by internally and externally rotating my arm, if I put my palm right on my shoulder, I can feel my greater and lesser tubercle moving around, right? I can come down and find the shaft. I can find that deltoid tuberosity. It is lower than you think it is. Then we have our capsule. This is probably why the shoulder, again, with a lot of older patients, gets injured, because the shoulder capsule is pretty close, in my opinion, to the wrist and the ankle as far as having a lot of stuff hanging out there. The good news is, again, the ligaments that make up the capsule are named from where they start to where they go. So the major one that we kind of worry about when we're talking about the shoulder capsule is the coracohumeral ligament, right? So the coracohumeral ligament. It's going to go from what to what? What's the starting point? Coraco, the coracoid, good, and then humeral going to the humerus, right? That ligament kind of keeps that shoulder, because it's kind of back in the back, it kind of keeps that shoulder locked into that glenoid fossa really well. Now, there are all of them out there. You've got your, glenohumeral ligaments, you got your capsule, you've got your, your acromial or coracoacromial ligament. You've got all these that are there, right? The main one when we're talking about the shoulder is going to be that coracohumeral ligament. So here we move down, here's our glenoid ligaments again. So our capsule itself, when we talk about the capsule of the shoulder, just like the hip, it's this stuff here. And when we start talking about capsular patterns, if you remember what that looks like, capsular patterns will make sense. So there's our glenoid fossa. Muscle of the shoulder, ant, middle, and post delt, right? We've got, you can also call middle delt lateral delt, so some books will call it lateral delt. Pec major, we have our sternal and clavicular portions. So remember, the pec major has two places it starts, right? Some of it starts from the clavicle, some of it starts from the sternum, right? And this comes into play when we start stretching patients, because what's the number one stretch we use to stretch a patient's pec sal? Does anyone know? The doorway stretch, where we'll have them put their arms on the side of a doorway. Your hand on wall works too, but usually the door is where we start them, where we put their hands on either side of the door and then lean in. And just by doing that, a lot of patients will be like, oh my God, that feels both horrible and so good, because we sit like this. So stretching that out and opening it up works well. Well, if we're at 90 degrees, we're stretching both the clavicular and the sternal portions. So a lot of times, a lot of clinics will do what's called three-way doorway. So they'll start at 90, they'll drop down to 45. And at 45, now you're stretching more of that clavicular portion. And then they'll come up to 135 where you're up here, and now you're stretching more of the sternal portion. Try that sometime. You'll feel the difference in the way it opens up your chest. The 135 degrees where I'm up here, here's 90, here's about 135. When I'm up here, that really feels uncomfortable to me. That means my sternal portion is really super tight. Here's our delts, right? Gee, I wonder where they insert at. Could it be the deltoid tuberosity? Never would have guessed that. The delts are responsible for a lot of our motion going away from the body, right? Our abduction, adduction, and extension. They're our prime movers. Yeah, I agree. Here's our pecs, right? We've got that clavicular portion. We've got that sternal portion. Note that the sternal portion is larger, obviously, than the clavicular portion. I've known patients to completely rip that clavicular portion off and still have fairly functional movement because that sternal portion is just so large. But again, right underneath that also, we've got our pec minor, right? So this is an area of the body where a lot of people get pain. And Tyler will tell you this, when you're working massage on a patient, this area here is an area that you can dig at and really relieves a lot of pain for most patients. Just because everyone gets stuck, and so this stuff will bind down to the fascia underneath. Yeah, right? They love it and they hate it. They love it afterwards. When you're doing it, not so much. But if you look, if I do a cross fiber motion, I'm going to hit not only my pecs, but also I'm going to hit my pec major, my pec minor. I'm going to nail them all with one little cross fiber type motion. A lot of pictures. Oh, yeah. Big time. Especially a kid I told you about back in Pennsylvania that was a pitcher and a quarterback that his scapulas go out 90 degrees. I still haven't found that picture. I have to find it. So then we've got our lat dorsi, right? Those big, broad muscles that everyone wants, or if you talk about people in the gym, they're the fan muscles that come out from the ribs and make them look like they're the dinosaur from Jurassic Park. You have teres major, right? Note teres major is not part of the rotator cuff, right? Your rotator cuff muscle is your sits muscles. Supraspinatus, infraspinatus, teres minor, subscap. Those are our primary rotators of the shoulder. Now, does that mean that other muscles don't do rotation? No, there are some others that have components of rotation. But your sits muscles are your normal muscles that handle that. And then we have the muscle a lot of people forget about is coracobrachialis, right? It's a useful stabilizer muscle. So we often forget about it, but sometimes that can be a muscle that's causing pain and impingement. So there's our big lats, right? And they attach, what are the lats attached to? What's this area down here called? This white stuff. That starts in the thorax, is on the back side of the back, and it's made of fascia. Come on, guys. You remember what this is called?
Thoracolumbar fascia.
There we go. Good. Right? Hey, we got it. Okay. I was trying to wake you all up. That's all. What you don't see here is we have other fascia that kind of lays on top of it that we've got this other muscle in the front that attaches to as well. Our girdle muscle, our transversus abdominis, right? Which is our girdle muscle that holds our belly in. That we worked on when we were doing that drawing in exercise. Those fascia kind of lay over each other, so you've got to make sure that if you're stretching those lats out, you also stretch a little bit and strengthen that girdle muscle because they all kind of work in concert. Right here we got our teres major. Right here's our coracobrachialis. If you look at it, it is a super duper Cooper tiny muscle, and no, sorry. Anyway, super duper Cooper tiny muscle. I got sidetracked by a text message. I apologize, from Dr. Reskin. But that muscle's job is really important. It helps, right? It helps assist with flexion. But the other thing it does is, because of the way it's angled, it pulls that scap or that humeral head back into that fossa, which really helps with stabilization. Now, there's not an exercise you can do. There's not a coracoacromial curl you can do, right? It's too small to isolate, but it's really important for that. And then here we've got what we're talking about when we talk about those rotators, how they kind of all attach on here, right? So we've got our subscap here. We've got our supraspinatus attaching here on either side of the bicipital groove. We have our infraspinatus and teres minor. All of those attach just distal to the humeral head. That's what allows them to kind of rotate the humerus. When you look at this kind of helps me when I saw this. When I see somebody that gets a rotator cuff tear, just this view here makes me understand why they have such problem moving that shoulder around and why they get a lot of pain when they get a rotator cuff tear, because all those muscles are so close together. You injure one of them, they're all going to be kind of painful. So there's supraspinatus, and again, one of the reasons we focus on supraspinatus is because of the way it passes right here at the AC joint. There's a lot of people that get impingement there, especially if they have a hooked acromial, which we'll talk about. There's teres minor and infraspinatus, right? There's our subscap, and again, this is another area where a lot of people will get trigger points. A lot of patients, and probably a lot of you guys, you may not know it, but you have trigger points in and on that subscap fossa. And so we will go in and relieve those trigger points. But when you think about it, that's between the ribs and the scapula, which means you have to go in deep with a blade hand to get in there to get pressure on those trigger points. Yeah, that hurts, right? But again, it's one of those when it hurts when you're having it done, but afterwards you're like, oh God, I didn't realize how much that was kind of sticking. And you get it loosened up and your shoulder does feel better, especially like Dylan said, pitchers. This is one of the releases I do a lot on pitchers and quarterbacks that they just absolutely love. They will scream and moan bloody murder while you're doing it, but it relieves a lot of pain. So this is kind of looking at everything wrapping around. Yeah, it helps with frozen. Well, we think it does, right? We still don't totally know what frozen shoulder is, so we think it helps with frozen shoulder. I often think frozen shoulder, I'm of the camp that I'm leaning towards frozen shoulder more being a neurological problem than a muscular problem, but you look at all these muscles attaching here, right? Wow, bam, 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 bam. All of those muscles help lay over that joint capsule we have and allow us to have a functional shoulder. There's that picture again. So we have an anatomical relation between the shoulder girdle and the shoulder joint, right? Remember I talked about it. There is a 2-to-1 ratio between it. For every 2 motions of shoulder flexion or abduction, right, that shoulder girdle is going to upwardly rotate by 1 degree or downwardly rotate if we're going into extension. You need to know your general muscle actions. You need to know which ones do flexion. You need to know which ones do extension. You need to know which ones do internal external rotation. When it comes to my classes, and you'll find out really quickly with this when we start getting into the lab in Therex, we'll talk about that in a bit. When I am talking about muscle actions, because I'm a little bit more neuro-based, I'm not so worried about individual muscles. I'm more worried about the groups of muscles. So I worry about the shoulder flexors. I worry about the shoulder extensors. I'm not so focused on anterior delt versus biceps doing shoulder flexion or coracobrachialis, right? I worry about just gross groups. When you get to Dr. Reskin's class, I'll tell you in Therex 2, she is really heavily focused when you're getting into the upper extremity on each individual muscle and understanding where the action, origin, and insertion of all those muscles are. So when I ask you a question that's talking about what muscles are responsible for, straightening your spine, I'm not looking for the individual back muscles. I'm looking for more the erector spinae root. Whereas she would be looking for more the actual individual muscles that are kind of going down that erector spinae. The muscles of the shoulder that kind of move the shoulder when you think about it. So we've got the delt, we've got biceps that's involved, we've got coracobrachialis, we've got posterior delt, we've got triceps, and we got all that rotator cuff, right? Most of the muscles are going to be contained within what plexus for nerve roots? What is going to provide? Yeah, the brachial plexus, right? So that means if I get injury to the lower portion of my brachial plexus, I'm going to knock out most of my shoulder motions if it's a severe injury, right? So if I do, I have a tear in the brachial plexus or something like that, it's going to knock my shoulder out. So we have to understand that if you have a high tear, you might have some motion. But if you have that really low, C8T1 tear, you're going to lose most of your motions of your shoulder. And that can be really problematic because, if they lose that, that's all the motion in the arm. That arm's going to become dead. It's going to eventually atrophy and it's going to contract. So that's why we worry about when we have somebody that's got Erb's palsy or whole arm palsy, getting as much of it back as we can as fast as we can. Again, I think I mentioned this in the nerve class, but what you have at 24 months is pretty much what you're going to get. And then at 48 months, it's fixed. So if you don't start working hard before 2 years, or I'm sorry, 24 months, not 48. If you don't start working hard at 2 years, you're done. Whatever you have is what you have. You're probably not getting anything else back. And that shoulder is so important for our function. Talk to somebody that's had a whole arm amputation and see how that's changed their life, right? That would totally botch me right now. I wouldn't know what to do if I lost one of my arms. So the force couple, right? So when we have arthrochromatic of the shoulder, we're moving things. Without the rotator cuff, they're going to perform individual actions. So supraspinatus, if we don't work in the force couple mode, is going to work for helping abduction with the delt. But supraspinatus is also then going to work in with the other rotator cuffs to allow for rotation. So this is kind of what that force couple looks like. It looks really complicated, right? So there's our supraspinatus, subscap, infra, and teres. When they work together, they will internally or externally and internally rotate that humerus, depending upon what pulls and what doesn't pull. They are also going to be responsible for stabilization. So if your internal rotators are active and contracting, your external rotators are going to be working eccentrically to control things. So that's why a lot of patients that we start getting them doing, external internal rotation exercises, man, the next day they're sore. Well, the reason for that is when we're doing those internal and external rotations, all of our muscles in our shoulder girdle, our glenohumeral that's activating, are firing, right? If you want to see it, when you go to the gym, add a day where you just do, internal rotation, external rotation, and a lot of just basic shoulder motions, and then see how your arm feels the next day. You think bicep fatigue is bad. You get deltoid fatigue and your arm just kind of hangs there. Like, oh, it's my arm. Great, I can hold my cup like this, but I can't drink, right? It's amazing how fatigued those little muscles get. But also, don't forget, they're really tiny muscles. So it's not like other than like subscap and supraspinatus, which are a little bit bigger, most of them in size-wise aren't like, your quads. They're tiny functional muscles. Do you think these muscles would be more aerobic or anaerobic muscles, the rotator cuff? Do we need a ton of force in the rotator cuff? Or do we need to be doing it more often? So they need to be a little bit more endurance-based. What do you think? Do you guys remember anoxic versus oxidative muscles? Red versus white muscles? A little bit? Not at all? Okay, good. Starting to think I was alone in the room. Thank you, Renee. At least I know everyone's here now. they're going to be a little bit more oxidative. They're going to be more red meat muscle, right? Because it's not like we're like, I'm going to pull 500 pounds with my rotator cuff, right? They're responsible for a lot of motion throughout the day, so they need endurance. That's why it's really hard. Like if you're somebody, you ever see those guys that do the like professional arm wrestling, right? I don't know if you've ever noticed, but sometimes the guys with the smaller arms actually win. Well, it's because it's not necessarily the bicep and the triceps that are important. It's those rotator cuff muscles. And if you're working that rotator cuff, you can become really good on arm wrestling because that's what you're doing, right? If the guy's pushing you back here, you're trying to eccentrically resist external rotation. Your goal is to get him into internal rotation and win. I know, right? Why didn't I learn this going through high school? Because we used to have arm wrestling all the time and I sucked at it. In the martial arts also, I talk about this a lot. I know I talk a lot about the martial arts, but in the martial arts, we use a lot of internal and external rotation motions to trap and to throw people. Oh God, yes. Where's that? Oh God, that is, I was watching that on ESPN the other day. I couldn't believe they had that on ESPN. The face slapping competitions. Yeah, they've got some serious, yeah, it is mainly Russians, right? But those dudes got some serious force behind their abduction. That is something, wow. I mean, I thought I punched hard, but those, you know, I'm pretty confident my ex-wife was a professional slap boxer. Oh, no joke. That was kind of funny. I thought it was hilarious. Get these hands. Anyway, some of you will get that, some of you won't. All right, so common shoulder pathologies. AC separation is really common. So you can get a grade 1, grade 2, or grade 3. Remember, that depends upon how much is torn. If you have a grade 1, it's just a minor stretch. Grade 2, you have a partial tear. Grade 3, adios, right? And it can either tear the acromioclavicular or the coracoacromial or both. This is a common pathology of quarterbacks, is an AC separation or an AC tear. Why is that? And people are like, I don't know. I don't follow football. That's okay. You're going to probably deal with some sort of person at an outpatient, right? Think of the position the quarterback throws from, right? Quarterback comes back like this and wings the ball, right? As a defender, when I played linebacker, my coach told us our target was right here. Why was that? Because if I hit there, the likelihood of them fumbling is pretty high. But also, I had one of those coaches, and I didn't realize it until after when I got out of high school, was he was a dirty coach. And so if I hit there, the likelihood of that person separating their shoulder and being out of the game was pretty high. Right? Yeah, right? I had a little bit of a dirty coach. Thank you, Mr. Rudisil. But it's really common. If you watch, yes, football form is sweeping the leg, exactly. Sweep the leg, Johnny. But if you watch, even at the pro level, some of the high-end speed linebackers do the same thing. Now, they may not go for body on that area, but man, that's where they're slapping. And so now I go back like this and I get hit, that AC joint is just going to rip open. If it's ripped enough, it's going to lose stability of the shoulder. That quarterback's out for 6 to 8 weeks, and they're probably going to need surgery. I think the last one that I saw had this was, what was the guy that was the quarterback for the Chargers? And then is now, I think, at Indy. Philip Crimea Rivers. That's it. Yes, thank you. For those of you that don't know, if you're interested, and this is kind of a funny story about Philip Rivers, if you've ever heard if you've ever heard the Godsmack song, crying like a, well, you can figure out what the last word is. That song was written for Philip Rivers. Because Godsmack are huge Patriots fans, and in the one playoff game, Phillip Rivers was sitting on the sideline crying, and so they made a song for him. All right, that was totally off track. Back on track. Yeah, he will be a Hall of Fame quarterback. You're right. There's no doubt about that. He's a good quarterback. I just laugh at him because I think he has. The funniest thing is, have you ever, truth story, if you ever get a chance to hear him on the line, he doesn't swear. So, like, the mic'd up portions of him are hilarious. Now, gosh dang it, people, can we just get our freaking stuff together? Clavicular fractures. Most common fracture in the human body is the clavicle. It is. It's dadgunnit. Yeah, that's his favorite one. Dadgunnit. When we fracture the clavicle, again, it's going to impact our shoulder stability, especially our posterior stability, because that clavicle is kind of useful for helping with that. Humeral fractures, again, are not funny breaks, but, you know, they are funny bone breaks. Shoulder dislocation. With a shoulder dislocation, which direction do you think is the most common for a shoulder dislocate? Anteriorly, posteriorly, superiorly, or inferiorly? Yep. So the most common is posterior and inferior, because a lot of our rotator cuff holds us, and it's really hard to go this way. I mean, just try to push your shoulder this way. You go back, you can feel that shoulder's got a lot of motion. And same thing, if you drop down, the only thing really holding it in at that point is anterior delt and supraspinatus. But when you're dealing with old people, that supraspinatus and those anterior delts and middle delts often waste away. So a lot of times those sublux inferiorly, which is where that humeral head just kind of slides down. They're not a full dislocation, but it's just sitting on the bottom part of that glenoid labral area, right? And I told you guys before that it's a labrum, not a labia. I've told you that story, right? Yeah, so make sure, labrum, not labia. I'm not going to show you where the labia is. If you don't know that by now, I can't help you. Impingement syndrome, right? Impingement can go any direction, but we're going to talk about when we get impingement, a lot of times it's going to deal with our capsular patterns. But impingement can happen at the supraspinatus. It can happen at the infraspinatus. It's just where that sort of shoulder locks up. Adhesive capsulitis, which is also let it go shoulder. Right? That's what people want. They want let it go shoulder to go away. Let it go, let it go. My shoulder is stuck in place. I have fun teaching. Can't you guys tell? Like, could you imagine just having like a boring teacher for this? I'm just awesome. I'm just joking. I don't know if that was great. Rotator cuff tears, really common in overuse or in excessive use, where you're doing stupid stuff like I did when I was shoveling, right? Lifting boxes, you can actually tear your rotator cuff. So don't help a friend move. Tell them, I value my rotator cuff. I can't help you move. What's LHB? Sounds like something on the West Coast, right? LHB for life. No? Okay. I thought it was funny. I find really weird things amusing. LHB, long head of the biceps. Good, right? A lot of patients get long head of the biceps injuries, right? From either, again, excessive use or overuse. They can get injuries and they can get ruptures, right? That's the last thing you want to hear is you rupture the bicep. And we're going to talk about, when we get down to the elbow, patients that get Popeye tears. So here's kind of an AC separation, right? So grade 1, we're just kind of pulled on it. Grade 2, you can start seeing things coming apart. And then grade 3, that's your problem right there, right? So now look at this. If we have this grade 3, there is literally nothing holding that clavicle in place. So they may need, if you've got a grade 3, they may need to go in and do surgical repair. Right? Now the good news is most of that surgical repair on that, when you have a grade 3 tear, is going to be arthroscopic, but that's not going to have the same structural rigidity as your natural ligaments. There's a clavicle fracture, right? That doesn't look very fun. Just, I mean, it's even red. That's not the way it appears in x-rays, by the way. This fracture is, this is actually Philip Rivers, or no, not Philip Rivers. This is Brett Favre's fracture. I stole that one. Sorry, Brett. But look at that. And the best part about that fracture was, does anyone know what the neat part about that fracture was? He played 2 more games. Before he realized he had a broken bone. I wasn't going to say a hey, you guys. All right, then we have a humeral fracture over here. This definitely one is not funny. Right? Is that a displaced fracture? You remember what a displaced fracture is? Yes, right? A displaced, so if this was a in-place fracture, the bone would be here, but it would still be broken. The bone itself is way over here now. Draw, right? So how are they going to fix that? They're going to have to pin it, good, right? But what are they going to have to do first? Has anyone ever seen them fix this? Yep. They're going to have to do traction on this. So they're going to have to pull this way, pull this way to pull them apart until they're yanked apart, until they can watch on x-ray that we can get them in a union. And then they're going to get them there. They're going to splint it for the time being and then into surgery to fix it. And probably, I'm guessing, all these little chunks here are going to have to come out. And that's a pretty big chunk there. I don't know if you see that, but that's a decent sized chunk. That's almost a, hey, you guys, chunk size. No? No? Oh, that one was funny. I don't care what you say. So what do you see a problem of here? Looking at this x-ray, look what looks like the problem. Okay, what's wrong with the humerus? What's it missing? The head's not out of socket. The head's actually in the socket. The head's off, yeah. The neck is broken. There's the humeral neck. Yeah, so this is a surgical fracture. Yeah. There's the humerus. How do you think that happened? Does anyone have a guess? Yep, good. It's a fouche, right? This is an older person with, what do you call it? Osteoporosis. So I'm guessing probably down here we have some more broken bones. I don't know. But just look at that. That humeral head's not even, there's no part of it anymore. So how are they going to fix this? Obviously surgery. Yeah, they're going to have to do a total reverse shoulder. Absolutely. I just love this picture. This is my favorite all-time physical therapy picture. I don't know why. This one and the next one are my 2 favorite pictures of all time. So this is shoulder dislocation. Anterior is most common when dealing with falls and strikes. Inferior and posteriorly are the most common in old people. So anterior is where I come this way just because that's what we get forced. So if you're getting pushed from behind, it can dislocate anterior. That requires a force. Gotcha. You see what I'm saying? That requires a force. Posteriorly, inferiorly can literally just happen. So forced shoulder and abduction lateral rotation are the usual cause of it. So force abduction, lateral rotation. Now I'm in this position. This is the position of apprehension, right? And why it's called apprehension is because if you put the patient in that position, you get this in this picture here. This picture is from, where's my book at? This picture, I can't find my book. I love that book. Where's it at? There is one book. What happened to my book? There's one book that actually was written in 1976 that still to this day has never been rewritten and is probably one of the best physical therapy books that have ever come out. It's called Spine in the Extremities. Hold on. I know I have it. Oh, there it is. It's hidden. So this book here, and you can see I still have my sticker on it from when I was in class. But this book here was written in 1976. In here, that picture, that's where this picture comes out of. It comes out of this book. They've got some great drawing pictures, some great pictures drawn in here and stuff like that. But this book came out in 1976 and has never been rewritten. It's that good. That's impressive, right? You know, Hoppenfeld made this book and it's stuck now for many, many years. So that's why I said, now notice when I said it requires a force, just going in this position is not going to dislocate you. If you notice, that clinician is now pushing forward, so an anterior dislocation requires force. Let me ask you a question. If I came in as a linebacker and hit that elbow right there, could I still accomplish the same thing? Would I still possibly get an anterior dislocation? Yeah, right? Because what's going to happen is I'm going to push that way. It's going to cause a rotational force that way on the shoulder. So that's why I said that posterior, inferior are the most common without force. Anterior is the most common with force. It's like those falls again. Under 65, the most common bone broken with a fall is what? Under 65, not the clavicle, that's the most broken bone in the body, but with a fall. The most common broken bone, that's over 65, close, scaphoid, there we go, right? So under 65, the most common broken bone in a fall is scaphoid from the fouche. Over 65, the most common broken bone is the hip in a fall. This is a similar thing here. With the shoulder, the most commonly dislocated with force is an anterior dislocation. The most common with non-force is inferior and posteriorly. Does that make sense? Good. I want to make sure I hit that. Because subluxation is really common in people. Overuse syndrome. This picture looks so weird to me. I'm not even going to comment, but it just looks really strange. Overuse is common in compression of the acromial arch, humeral head, and soft tissue. So all of this area swells up. That's some serious swelling there, I'm just saying. But when that happens, you got to think about it. Literally, there's only a few millimeters of space in the shoulder. So any amount of swelling in that shoulder is going to cause compression. When we get compression, we have loss of motion. So any amount of overuse is going to do that. Again, quarterbacks and pitchers, really common to have overuse swelling in the shoulder, right? And you know, Dylan will tell you, most pitchers that pitch for several games, as soon as they're out of the pitching, off the pitching mound and in the locker room, they've got ice on that shoulder because it's just going to be swollen and sore. Adhesive capsulitis, again, inflammation and fibrosis of the shoulder joint, often referred to as let it go shoulder. But understand, with adhesive capsulitis, what fixes frozen shoulder? Does anyone know? No one knows, right? That's the thing. this is one of those times where the patient's gonna come into you one day and be like, oh my God, you know how I was limited here? Watch this now. They're gonna be like, you are a miracle worker. And that's where you just go, yeah, I know. Just, I'm awesome. I don't want to tell you. I just do it for everybody, right? I've had patients come in for one treatment with frozen shoulder and they walk out better. And then I've had other treatments where the guy's been going for 10 weeks and he's still frozen. So that's why, personally, again, this is not evidence-based. This is anecdotal. I really believe there's more than just swelling and fibrosis. I really think there's probably a neurological component that goes along with it. Something either central or peripheral sensitization, which we'll talk about in neuro. But it just kind of freezes up, right? So a lot of times we'll have the inflammation on bicipital groove, subacromial bursae will swell. Again, what causes it? I don't know. Let me ask you this though. Because it's frozen, and I've heard this before, it's frozen shoulder, so I don't want to use ice. Has anyone ever heard that? That's fantastic. I love when I hear that. It's already frozen. No, right? Because if we're looking at this here, just this picture, the problem is swelling. What if this was what the inside of that shoulder joint looked like and you added heat to it? What would happen? Yeah, it's going to make it swell, right? So that's where it's going to come into play with your clinical judgment. Is the patient in an acute flare or are they in a chronic flare? Most of the patients will want heat because heat has a soothing effect to us. Most patients don't want cold because cold is uncomfortable, right? But you've got to pay attention. Are they an acute flare or chronic flare and what that swelling type is? Here's rotator cuff tears. All this stuff can happen, and this is kind of a supraspinatus tear here. You can get teres tear, you can get a subscap tear. Any of those can happen. I will say, again, anecdotally, that if the patient has had a tear, I have found that my patients have gotten better just with traditional treatment and physical therapy than they do when they go in for surgery. A lot of times when I have a patient that goes in for rotator cuff surgery, they come out worse off. And again, anecdotally, not research. There is some research out there that shows that physical therapy does better than rotator cuff repair surgery. You've got plenty of other rotators in there. Unless you've torn them all, your shoulder can compensate. It may not be as strong, but it can compensate. Anytime you cut into the body, you start leading to problems. And what they're going to do for this is they're going to go in, they're going to break out the good old green stitches because most of the stitches are green. And they're going to stitch that. Now, once they've got that nice and stitched up, down here we have that fascial layer. Guess what's going to happen to those stitches in that fascial layer? Because those stitches are kind of plasticky. They're going to stick down to that fascial layer. And so now you've got an adhesion in that shoulder, and that causes a problem. It's going to dig down, exactly. Why is this not going on anywhere? Oh, because the video. We'll look at this video tomorrow. I don't want to do, I want to kind of let you guys go here in a few minutes. Don't play.
Rotator.
I got a video of the rotator cuff. So here's a long head of the biceps tear. This is where that long head, right, rips off. So here's our short head. Remember, your short head kind of passes more medially than your long head. When that tears off, this is what, so, oh, no, I don't want to do that. Go back. I clicked instead of, that's shoulder arthroplasty. There we go. So when that tears off, the bicep will roll that way. When you have a Popeye tear, if it tears off down here, the biceps will go that way. So that can cause all kinds of problems. All right, so I've got a couple surgeries I want to watch with you guys. I think we'll talk about that tomorrow. We'll start with that tomorrow. Let me stop share here and stop recording. Where's my mouse?